There we go. Hi, Cam followers. It's so lovely to see you, and see you virtually today. And we have got some exciting stuff for you because Diane is going to follow up on our series on lumbosacral disease, following Tom from yesterday. And she's going to have a look at sort of the rehabilitation and the physio side. So that's going to be really great to wrap up this week's series. So I'm going to pass over to you, Diane, and let you introduce yourself, if that's okay.
Thank you, Amy. Hi, Cam followers. My name's Di, and I currently work at Davies Veterinary Specialists in Hertfordshire. I've been there since 2011 and head up the team of therapists in our therapy centre. So I guess my background, I started out as a human physiotherapist in 2002 and worked in human medicine for 12 years before solely transferring over to small animal medicine. And I work with a fantastic team at Davies. So I work with orthopaedic and neurologists there. And it's, I can't describe what an amazing setup we have there. I'm very, very fortunate. But so tonight I'm going to be talking to you about lumbosacral disease, following up from Tom's amazing talk yesterday, and hopefully revisiting some of the anatomy and what it is, and then looking at what we can do from a conservative approach. So I hope you enjoy this evening.
Yeah, it's going to be great. So we're just going to share Diane's screen. So we'll get that up, and then we'll start the presentation then.
I'm not sure whether I. Oh, there we go.
Hi Tina. Hi Julie.
Hello Amy. Can you see that screen?
The screen hasn't come up on my end at the moment.
It keeps. Sorry about this, Cam followers. We did practice.
We did. No, it's okay. It gives everyone some time to arrive with their cup of tea. I've got mine here.
Now it is flashing in and out, so I'm sorry about this.
That's okay, don't worry.
May need to just close it down for a second. Whilst I'm just trying to launch this, I had a close shave just literally seconds before we were about to launch, with my son walking into the room. So I hope that will not happen again this evening.
Bless him.
But Tom's son came to say goodnight to him last night. And
oh yeah, they were so cute, weren't they, coming in to say goodnight.
So can you
yes,
see that
that's here now. Yeah, I'll add that to the stream, and then we'll make us disappear for the duration of the slideshow so that we can see them big. There we go.
So I said to Amy that she can chip in with any questions or comments along this evening. So if anybody has any questions that Amy can see, then hopefully she can stop me along the way. Otherwise, I'm happy to answer questions at the end of the talk. But hopefully, enjoy. So the lumbosacral junction is the lowest part of the dog's back, essentially. So this is the area we're focusing on this evening. And essentially, it's where the lumbar spine articulates with the sacrum. So you have 7 lumbar vertebrae, and the 7th lumbar vertebra will articulate with the sacrum. And at that point, you've got the disc as well, the intervertebral disc, which sits between those bones. And on the right here, you just can't see it on this photo. I tried to get as clear an image as possible. You've got these parts of the intervertebral foramen, which is where the nerves will exit from the spinal column. So you have the spinal cord that runs down the centre of the... There's a lot of feedback, sorry, Amy. I'm not sure.
Oh, hang on, let me mute myself and that might make it better.
Oh, that's better, if that's okay. So you have the spinal cord that runs down through the intervertebral foramen, and then you've got these peripheral nerves which will exit at these holes, if you can see my pointer. And so this image, this slide just shows it in a little bit more detail. So the larger slide on the left lower part of this slide is essentially a slice. So it's sliced longitudinally down through the vertebra. And so where you can see the intervertebral foramen here, this is where the spinal cord would sit. And then they would exit through these holes, these smaller foramen. And so what you have in this case, you've got the spinal cord, which at the top is protected by the interarcuate ligament and the lamina of the vertebra, so of L7 and S1. On the sides, it's protected by the intervertebral foramen and the pedicles, we call them pedicles of L7 and S1. And then on the bottom, you've got the dorsal longitudinal ligament and the intervertebral disc and the neighbouring vertebral bodies. So the spinal cord itself, it comes to an endpoint and is located in the caudal half, so the lower part of L6, where you can see here the white portion on the right-hand side. And that's where it arises to what we call the cauda equina. So the cauda equina is composed of spinal nerves, and they extend further down into the tail. And then also they supply the hind limbs, the anus, and also the genitals as well. So lumbosacral disc disease, essentially it's degeneration of the lumbosacral junction or joint and or compression of the associated nerves. It is the highest motion joint of the spine, and the lumbar spine is highly mobile, but the sacrum is immobile, and that results in this transition zone. And as a result, the stress is placed on that joint and the lumbosacral intervertebral disc itself as well. And that can give rise to a disc protrusion, which is more common, and we call it a type 2 disc, or a tearing of the disc, which is a type 1 disc, and that's less common essentially. And that's when you can get nerve impingement, which can occur similar to like us. It's similar to sciatica. When the nerves are compressed, they can become inflamed, painful, and they might not conduct those electrical impulses as well as they should do. And that's when you start to get neurological deficits that you might see as well. So this is a video that I just created last week at work, and it just shows me moving L3 and L4 of the lumbar spine, so the third and fourth vertebra of the lumbar spine. And then this is the lumbosacral junction. So this is where L7 articulates with the sacrum, and articulate means just moves against the bones, move against each other. So you can see there's a little bit more extension there. I'm going to just play that again. I'm going to leap through to the lumbosacral junction. So the foramen where the peripheral nerve exits is just sat here. And what happens is, as that facet joint, we call these facet joints, as it glides downwards, it starts to close down on the foramen, which is where the peripheral nerve would otherwise exit. And that's when we can start getting problems. Now, this is just the spine itself. This is just the skeleton, and obviously we've got lots of ligaments and muscles around those that joint that's going to have quite a large impact on what happens there too. So what dogs are more vulnerable to lumbosacral disease? Well, it's commonly in larger breed dogs, and more commonly the German Shepherds, Dalmatians and Labradors. However, it can also affect those medium-sized dogs, and occasionally is seen in cats too. Coming back now to, I think they touched upon it, and Hannah and Tom was speaking about it last night, but they were talking about the different components of this lumbosacral junction that can contribute to this lumbosacral disc disease or lumbosacral disease. And so we've got two images which are quite similar, but one just shows it in a little, indicated the two other things that I couldn't find on the first one on the left hand side. But basically letter A, you can see where the bulging disc is. So you've got this intervertebral disc, and what's happening is it's starting to bulge, and you can see it's just rising dorsally there. So we call it dorsal, which means upwards towards the spinous processes of the spine, which is those knobbly bits down the spine, and that's pushing onto the spinal cord. So that's going to be quite uncomfortable in some cases. Then you can get thickening of the dorsal annulus fibrosus. So we were talking about, we often refer to them as jam donuts. It's quite an easy way of thinking about it. So basically, you've got this fibrous outer part of the disc, and then you've got this jelly-like substance in the middle of the disc as well. What you can see here is the centre of the disc, the nucleus pulposus, is just pushing upwards towards that spinal cord there. And then you can also get thickening through this dorsal part of the intervertebral disc. You can also get instability with subluxation. So what that means is that there's excess movement that can occur through this lumbosacral junction, so where L7 articulates with the sacrum, essentially. And what that can do is result in this sacral part of the spine translating lower down, so we call it ventrally, so going downwards towards the foot, I suppose, if you want to imagine it that way. And that can also cause problems in around what's happening in the spinal cord, so it results in compression as a result of that translation. You can get osteophytes forming, so these are extra bits of bone, essentially. I don't know where my pointer's gone. So you can see these are starting to rise here and just at the top here where the facet joints are. And they can also cause problems. And we were talking about spondylosis last night, about how you start to get these bony deposits coming together, and ultimately in some cases they might fuse as well. You can get articulate process joint capsule thickening, so where the, I was talking about the facet, so where you saw it gliding on the video just previously, you can start to get thickening of the joint capsule around that. And then you can also get thickening of the ligamentum flavum, which is a ligament which just sits on the top of the spinal cord here, and that can start to cause compression as well of the spinal cord. So the image on the top left here just shows a different view of the vertebra and the associated disc and the spinal cord. So you've got the spinal cord right in the centre here with the dorsal root and the grey and white matter. And you've got these peripheral nerves which arise from the spinal cord, these blue structures here. And they're just coming out of the those foramen either side of the main intervertebral foramen. And then you've got the disc, which sits, which is this blue part in the lower part here. And this illustration does show an extrusion, which I said was the less common, but nevertheless, I've just hoped that it would illustrate how it can also affect one side of the spinal cord and the associated peripheral nerves. So peripheral nerve is the nerve essentially that branches off the spinal cord, and that can cause pain into the limb that it's on the side that it's affected. So we can see that a lot, and we'll talk about that again. And then the video just here again was just again focusing on that spine. So showing you again what happens in this lower part here. And you can see how it extends the sacrum onto that L7. Okay.
Sorry, Di, just to interrupt. We can't see your pointer. So when you're explaining, we can't see where you're pointing to. So just so that you know, sorry.
That's perfect. No, I'll try. Is there anything that I didn't make clear, Amy, or is it all right so far? I tried to.
I think the only thing is explaining what the foramen is.
Okay.
Yeah, so if that's okay.
Yeah, no, that's fine. So the foramen is basically the hole or the tunnel, essentially, that the spinal cord will pass through. And then you have these smaller holes that come off the main tunnel that allow those peripheral nerves to come out and exit. And that travels then down into each of the limbs.
That's perfect. Thank you.
Thanks, Amy. So what are the clinical signs of lumbosacral disease? And I essentially wanted to list this because I think there may be watchers currently with us that are sort of seeing some of these signs in their pet, but not really knowing that it might mean something. So we often see or have owners tell us that their pet is having difficulty in getting up, they're sitting down or lying down. Now, this image on the right-hand side shows this lovely Labrador, but what he's doing is sitting with his hind limbs into what we call protraction, so they're forward rather than nicely tucked underneath him. And what he's doing, he's trying to rock his pelvis back. Now, from a physio point of view, we would call that a posterior pelvic tilt. So he's rolling his pelvis back to put his spine into flexion, which is the most comfortable position for him. Because in the video you saw previously, as the spine extends, that's when those smaller tunnels where the peripheral nerves that supply the limbs exit, that's when things get narrower. So the position of comfort for our pets is to try and get ourselves or get themselves into flexion, to try and make sure that there's enough space for those nerves to exit. And so we might see postures such as this in the photograph here, from our pets. And I had a case this week as well that was doing just that. A lovely dog that I'm seeing for what I originally was referred to for iliopsoas problems. And yes, we do have problems around iliopsoas, and I know this came up in conversation yesterday. Yeah. However, he also does have some signs of lumbosacral disease, so I am referring him back to the surgeon within our practice to just revisit this. And what he's doing is sitting similarly, but he sort of will start to sit in a nice tidy sit, but then he'll rock his pelvis back into flexion and then externally rotate the limbs. So externally rotate the limbs means that he's taking the knee joints outwards and trying to get him into the most comfortable position. So unfortunately I didn't catch him quick enough to take a photo for this talk this evening, but it would have been another good illustration. Other symptoms are reluctance to climb stairs, jumping or working, if they're working dogs. They may get lower back pain or hind limb pain. And this can be seen in the way that they might be chewing or nibbling in the lumbosacral area, or they might be nibbling their hind limb as well. So we might also see that. We might also turn to look at their back. And I've also had owners report that they have been looking at their back quickly as if they've been stung by something. And that can be a real catching pain or a sign of catching pain. So it's not something to be dismissed. And I've certainly got an owner at the moment that's seeing that in her pet. And the only other thing that she's noticed different in her pet, and she's very in tune with her dog, is that when she's posturing to urinate, she's lifting the left hind leg. So I'm not sure whether that's of any clinical significance, but it's certainly something that that we have, we are certainly bearing in mind as well. Hind limb lameness, so we can see lameness as well when they have leg pain. And for those of you that have experienced lower back pain and sciatic symptoms yourself, you may know what that feels like. We can also then, you may see more extreme cases where you start to see weakness in the hind limbs. And that can be with or without scuffing of the toes. So there's some cases that I'm seeing that the owners are very in tune with the pet. When they're on a tarmac or asphalt surface, they start to hear the scuffing of the nails. And that's when they know that they're a little bit worse than they normally are, because that tends to improve when we're treating them in some cases. We can see hind limb coordination. So maybe changes to the gait. Maybe they're starting to pace instead of adopting a nice 4-beat walking gait. Difficulty in posturing for the toilet. They might be have a weak or reluctance to wag their tail, and they might be low set in their tail posture. So you might see a dog with its tail down, tucked between the legs, or certainly just not having any tone at all. And then worst case scenario is when you start to see urinary or fecal incontinence. So that's when you're getting to that stage, that would suggest to me that it needs an urgent referral to a neurologist. So I've got a couple of videos which I'm just going to have a little play around with this slide, because they are on YouTube, so it's quite difficult. Can you still see that, Amy?
Yeah, that's all working nicely.
Perfect. So I'm just going to jump up to this. So I just wanted to look at different clinical signs, and I'm just going to jump forward to the stairs. So dogs, when they're doing the stairs, normally will take them hopefully reciprocally if they're large enough. If they're sort of medium to large breed dogs, on a standard step. And you can see they step up and they start to extend through their hip area, but they're also putting a little bit of extension through their back. And in some cases that can be uncomfortable for our pets. So we go to the next video, which I've got. Some cases I've seen or I've heard of dogs demonstrating climbing stairs in a similar way to this. So obviously this is a YouTube video which is described as a dog being scared by the cat's ghost. However,
oh wow,
the way this dog is climbing upstairs, to me that would raise some alarm bells on whether that dog's in pain. So he's trying to keep himself into flexion through that caudal lumbar area, that lower lumbar spine, and trying to do it in the most comfortable way that he knows. And I've had owners also describe to me when their pets have been allowed on and off the sofa that their pet, in order to get off the sofa and avoid extension through that lumbosacral area, they have actually positioned their bottom on the sofa cushion and slid themselves off instead of standing and stepping off in their normal way. So look out for these things, and that's probably quite unusual to see that, but some of you may have heard or know of that happening.
You can still see how tucked his bottom is though, isn't it? It's tucked right under, isn't it?
Absolutely.
Under himself.
And then jumping onto and off this bed as well is another thing. And I also stumbled across this video. And it, you know, they think that this dog is floating. However, you can see that dog just doesn't want to extend through its lumbosacral junction. I'm not sure whether it's the same dog. It looks very similar to the previous one. But I just wanted to highlight that because I think, you know, it tells
so he's keeping all his legs sort of really rigid, isn't he, as he just plops off the bed. Yeah, it's very abnormal.
So bless him. So physical examination, and this will be similar for obviously veterinary surgeons, specialists that you might be seeing, or for ourselves as well. So there will be a full clinical workup here, and the sorts of things you might see when we're examining these cases, obviously having taken the full history from yourself, is that we get, when we examine the case, we start to see things like the pain on direct palpation of the lumbosacral junction. Pain can be elicited on extension of the lumbosacral junction, and there's different ways to do that. Some are better than others. I'm not a fan of some of the techniques to try and elicit pain on extension of the lumbosacral junction, but each practitioner will choose their preferred technique. And also, I think at this point as well, it's really important to identify if you are testing lumbosacral junction extension by extending the limbs to do so. So you're actually tipping the pelvis into extension as well. So we call it anterior tilt. Then it's really important to understand whether you're identifying lumbosacral pain or whether it's hip pain as well. So it's, there's a few techniques that you can utilize in order to differentiate which is the cause of pain in your patient's case.
Yes, I was reading that paper that I just shared, and I think, did they say they were talking about being very careful about misdiagnosing it because it could well be the hips, but they tended to get the dog lying down on their side. So then when they extended the legs, it had minimal impact on the lumbosacral area. Is that what you tend to do? Yeah.
It is, yeah. So that's one of the ways that you might do it. So if they're lying on their side, what you can do is apply some pressure over the seventh vertebra and then start to take their limbs into extension. If you do that as well, you find that you don't take the hips into full extension, but you're still getting quite a lot of extension through the lumbosacral area. So you'll get that first before you get a full hip extension.
Right.
So it's a really nice way of testing it. And then another orthopaedic surgeon I used to work with, and actually I haven't asked the ones that I currently work with, but he used to place his hand under the pelvis, so under the floor of the pelvis, as we might call it, and apply pressure over the seventh vertebra and then extend, so not influencing the hips in any way. And that was a nice way of testing as well.
Yes.
So we can see hind limb weakness, which is identified when we analyse the gait and during some of the transfers we might see. And what I mean by transfers is sort of sit to stand or lying to sitting and standing. So we when we're in the assessment room, when we're treating or assessing the patient, what I tend to do is invite the patient in. Obviously, at the moment, owners aren't allowed into our treatment facility, but I usually have the patient walking around the room whilst I'm just adding to my notes, and I'm watching them all of the time to see what they're doing and what their position of comfort is, and just getting a general picture of what's going on, really. So we also might see muscle atrophy of the muscles innervated by the sciatic nerve, and Tom was talking last night about how he sees a big difference in certainly the biceps femoris, which is one of the hamstring muscles, and also reduced tone overall globally through the hamstrings. So the L7 nerve root or peripheral nerve supplies the hamstring group and then comes down into the lower part of the limb below the knee joint itself, the stifle. And so we start to see a loss of tone and muscle bulk or mass in those hamstring muscle groups, particularly because they're such large structures. We also might see reduced reflex withdrawal or the cranial tibial reflexes. So these are reflexes in the lower limb as well. And also I popped in the myofascial trigger points here, and I suppose from a physiotherapist point of view, which is where I come from, we are also looking at the rest of the body, and we're looking at the impact on the whole dog. So we'll identify, Tom referred to it last night, that his physio team as well also identify myofascial trigger points and treat these. And there are areas of localized guarding, I suppose, in the paraspinal muscles, the muscles that run alongside the spine as well. So if you imagine the dog's trying to reduce the pain, it's going to be working harder through the front end of its body and overactive through the nerves further forwards as it sort of tries to transfer its weight to minimize the pain, essentially. So yes, we also treat these too. So another test that we utilize in the human medicine is this straight leg raise. So basically it's a method we use to tension the nerve. And you can see on the left-hand side is how we would get ourselves lying on the bed on our back. And what we would start to do is normally we would dorsiflex, which means we would bring the toes up towards us. So you start to tension the nerve at the lowest part. We'd keep the knee straight, and then we'd slowly elevate the foot. Normally the physiotherapist would be manually lifting the leg, passively lifting the leg themselves, and communicating with their patient the whole time, asking them to tell them when it's painful. And you can see what's happening with there's the yellow line that runs through the intervertebral foramen that you can see in that circle on the left hand side. And what's happening is you're tensioning that nerve, and the bulging disc in this case is pushing into that nerve, and that's going to give rise to more pain and discomfort. Now, there has been a study done, if I'm correct, at Liverpool University, and they looked at reproducing this in the dog as well. So it has been proven to increase tension through the sciatic nerve by doing a similar technique. So what we would do in our case is we position our patient inside lying. We would try and make sure that the toes were extended, or dorsiflex, so bring those toes up. We'd make sure that the tarsus was slightly flexed whilst the knee was extended as fully as it could be, and then we would slowly take the limb forwards. If we felt that you weren't getting any reaction, you wanted to double check that there wasn't anything further beyond that movement that you've already executed, then we might put some head and neck flexion on as well, which would start to tension it at the top end of the spinal cord. And that can be often provocative as well. So we can reproduce this test as well in our small animals. Oh, going backwards. So let's lead on to conservative management. So home modifications. So if you've got a patient with lumbosacral disease, there are lots of things around the home that we need to consider. So changes to the environment. And you've seen a dog jump off the bed, assuming that it's jumped onto the bed itself. Stairs as well, we've also talked about that and how that can provoke symptoms. So anything really that's going to place the lumbosacral spine into extension is potentially going to aggravate symptoms and cause pain. Weight management as well can have a major effect on the pet symptoms as well. So making sure that their weight is well managed. And I think Hannah's also had experience of this, with Mike having mentioned to her previously that she needed to get her pet's weight down. So when with Holly.
Yeah, bless Holly, yeah.
Yeah. So I think Hannah's experienced it firsthand. And anti-inflammatory medications, which I'm not going to talk about because it's not my area of expertise. But also in that category, you would perhaps look at the epidural steroid injections as well. That could fall into that category. And there is very strong evidence to support the use of epidural steroids in human medicine, as it is with small animal. But as Tom was suggesting, it's quite an expensive route to go down. So that needs to be considered as well. Exercise modification, so initial rest in the short term with modified exercise in the long term. However, that's not to say that they can't do some therapeutic exercises and specific targeted exercises, which we're going to talk about. And then physiotherapy will also include manual therapies and or electrotherapies as well. Hydrotherapy is not to be dismissed. We collectively as a team, in agreement with the neurologists and orthopaedic surgeons as well at work, we don't support swimming usually in these cases. And I'll show you a couple of videos in a second to illustrate our reasoning. But we do use the underwater treadmill for our patients. And then we've also got shockwave therapy and acupuncture as well. So I work with a fantastic team of anaesthetists, and they come and work with our pain clinic team to deliver acupuncture for our patients that are referred to that team. Okay, so before we move on to the video, maybe a bit premature actually, I'm not quite on that video yet for the hydrotherapy, but this was an article recently that I just pulled up as I was preparing for this evening, and it just looks at the non-surgical treatments for patients with radicular pain and lumbosacral disc herniation. So this is in human medicine essentially. And the outcome of this paper was basically saying bed rest is a big no-no now. Heat, but they were referring to, I don't know why traction fell into this category, but I think they're more specific to ultrasound and laser, was saying, yes, that is beneficial. TENS was inconclusive, and for those of you that don't know what TENS is or haven't heard of that, it's otherwise known as transcutaneous electrical nerve stimulation. With experience, it's good for chronic pain patients in human medicine. Basically, it's a machine that you apply pads to, in our case, the lumbar spine here, the lower lumbar spine. We might box off the area. And basically, it delivers an electrical impulse which will override the nerve and pain messages to the brain to try and dampen down that pain response. And there's a slide further on in a second which will explain how it can do that in addition to other therapies as well. Manual therapy, exercise and traction are all yeses as well in human medicine. So moving on to the exercise aspects of treatment. So in people, chronic low back pain in people is associated with muscle atrophy, which means reduction in muscle mass and asymmetry, resulting in one side being
That's my naughty dog, sorry.
Don't worry, at least it's not my son. And so they see this particularly in multifidus, which is an important stabilizer within the spine. And there has been a paper or a thesis that looked at this, and they found a significant reduction and asymmetry of multifidus seen in dogs with degenerative lumbosacral stenosis. So as I mentioned, it is important for spinal stability, and human studies have shown an improvement of lower back pain, a reduced reoccurrence of back pain, and an increase in that muscle size of multifidus in response to exercises which target that muscle. So it goes on to say, well, we really should be looking at doing the same thing for our small animals as well. And you can see on the MRI scan here how they've looked at the cross-sectional area of the multifidus. And on the right-hand side, you can see that that area is much smaller than the left-hand side as well. So something you can look back on if you've got pets or patients that have gone through the MRI scanner. You can perhaps pick up on that asymmetry if you look closely. Okay. So, as I mentioned, the multifidus is one of the main stabilizers in the spine, and that usually works with what's called transversus abdominis. I haven't got an illustration here, but essentially the multifidus contracts first to stabilize the base, which is our spine, from which the mobilizers can then function. So the mobilizers are the muscles that are, you know, moving our lower extremities essentially, so our legs. So we've got to make sure we have a good core first before we can take a step forwards, for example, because if we didn't have it switching on in a timely fashion, that multifidus, it could lead to injury because we're not preparing ourselves and we're not trying to find the right word. We're not stable enough to execute those dynamic movements, essentially. So insufficient or delayed stabilization or contraction will result in incorrect movement patterns. And you might be going to a physio or a rehabilitation therapist, and they've used these terms. And I just wanted to pop this slide in because hopefully I'll just clarify what we mean when we're talking about core stability or dynamic stability. You know, my owners are probably, you know, thinking the same thing. So I say, oh, we're doing this exercise to improve your core and dynamic stabilizers or stability. And then like, well, what's that? So I do go on to then explain what it is. So core stability is the ability to maintain postural stability and orientation with the centre of mass over the base of support and body at rest. So basically it's the ability for you to maintain a static position, so maintain your standing, maintain yourself in sitting, and you know, you've got to have pretty good core stability to maintain a good stance, solid stance. And if that was compromised, you might see a bit of a sway in the body. So I sometimes refer to it as lateral stability in the hind limbs. So if I'm seeing a pet in standing that's swaying on the hind limbs, I might refer to it as reduced lateral stability too. Dynamic stability, on the other hand, is the ability to maintain postural stability and orientation with the centre of mass over the base of support while the body parts are in motion. So what that means is it's the ability to stabilise the spine whilst you're, for example, running or ascending a ladder, for example, or walking upstairs. So you've got to make sure that your body can prepare itself to execute those movements and move the extremities in the direction that you want them to as well. These are some examples of static and dynamic exercises. So static exercises, essentially, we refer to as exercises that are done on a solid base, in standing or sitting, for example. And we might get patients doing what we call rhythmical perturbations, so knocking them off balance, getting the muscles firing quickly, which is in the top left-hand corner there. We've also got some static movements, sort of the third picture along on the top there. We've got a 3-leg stand, so we're lifting one of the legs off the ground. So for those of you that attend Pilates or have done something similar, you'll have yourself in 4-point kneeling, and you might be told to extend and elevate your hind limb, or sorry, not hind limb in our case, but our right leg. And what we've got to do is try and maintain our stability through our spine. So when I was treating my human patients, I would place a ball on their back and I'd say, okay, that ball's not allowed to roll off the back. So we've got to keep your pelvis nice and steady. However, if you haven't got good core control there, you'd quite quickly see the ball rolling off the back. So it's a really nice way of monitoring your position and posture. And that's what we're looking for as well when we're executing this in our small animal patients. Progression of that would be the Superman, which is the picture just underneath that. So elevating the forelimb as well on the opposite side to the diagonal pair. You can start adding in dynamic movements, so baited movements, just as the bottom left-hand picture illustrates. And there is some work that's been done in horses that have shown an increase in cross-sectional area of multifidus with the execution of these exercises. From recollection, I think the study looked at over 12 weeks in these groups of horses. They had them every day performing 5 movements to the right, to the left between the legs. And that was every day over 12 weeks, and that's improved cross-sectional area of multifidus. So that's in the horse population, as I said. And then you've got other dynamic movements like weaving and stepping over poles as well. So just some examples that we might do, but I should emphasize these shouldn't be done without the guidance of a rehabilitation therapist. So, okay. So there is so this is the Henderson paper, the thesis I was referring to, and they looked at military working dogs with lumbosacral dysfunction, and they showed, when they examined these patients, it did show that there was a reduction in cross-sectional area of multifidus. And what they did, they ran them through an 8-week course strengthening program where they found there's an improvement in symmetry, because there's a lot of asymmetry originally, an improvement in size of multifidus, and also a significant improvement in performance. So I think a nice outcome for those cases that went through that core strengthening program. So exercising in water. So we have swimming versus underwater treadmill therapy. These are the two forms of hydrotherapy that we have for our patients, our pets. And properties of water that we are particularly interested in is temperature. So that will help with increased blood flow, cell metabolism and toxin elimination, and also helps with pain relief and relaxation as well. Surface tension relies on cohesive forces between the liquid molecules, and that makes it harder for for us to pass through. So the way I liken it to, I tend to, and this comes with the viscosity as well, but I say to my owners, my pet owners, I say, oh, imagine you're in a swimming pool and you're walking through the water at a shallow depth, and then try walking through the water at a deeper depth, and then try increasing your speed through that. And I'll notice there's a significant difference the higher the water level goes. And so when we're using particularly the underwater treadmill, we do bear that in mind as well, because obviously the faster the treadmill's moving, the harder it is for the patient. So we're constantly monitoring the parameters within the underwater treadmill environment, depending on the water depth too. And the water depth is quite important because the buoyancy creates an upward force, and the higher the water depth, the greater buoyancy you have. So you reduce the load on affected joints. And so that's desirable for a lot of our patients, particularly with osteoarthritis of the joints. But if you start increasing the belt at that higher water level, a belt speed at that higher level, it is going to be a lot harder for them. And you've got to think about the external forces on those joints as well with that increased speed. So you always have to bear these things in mind. And then the hydrostatic pressure as well, that can improve posture within the water. And if there is swelling around distal joints, I know we're not talking about that specifically this evening, but if there's swelling of those lower joints, then that can help with venous return and swelling as well. So I'm just going to bob out of this again because we're going to go back to a YouTube video. Hopefully you can see this. So this is a little terrier who is swimming quite actively. And you can see that if you look at his pelvis and what his limbs are doing, I'm going to play that again if I can. Let's go back to the beginning. He's not phased at all by his swimming action. He's got a lovely hind limb gait action. He's happy to extend through that lumbosacral region, popping the pelvis into what we call anterior tilt, and is really engaged in his swimming. But if we look at this next patient, okay, note the breed. Unfortunately, he's one of the higher risk ones. Come on. There we go. And he's a bit more of a casual swimmer, but look at what his hind limbs are doing, not really extending. And that might be completely normal for him. However, it might also be him trying to protect himself and stop himself from going into extension through that lumbosacral region. So if you're seeing that in some of your patients when they're swimming, or some of your pets when they're swimming, then maybe worth just considering that, essentially. Let me come back to the screen. Oops. Okay, so, and this is finally the underwater treadmill. So you can see this patient's walking with the water at quite a high depth there, so he's got quite a lot of buoyancy. And nice treadmill speed at the moment, not too much resistance for him, but quite supported because he's got his limbs on the ground, so it's more controlled than the swimming environment. The swimming environment isn't as controlled because they're free swimming. Some dogs might feel a bit overwhelmed because they feel out of their depth. And obviously you aren't able to be in control of what they're doing through their bodies and their limbs as well, unless you're swimming right, in the water right next to them and guiding them in the direction you want to go in. Nevertheless, you're not going to be able to influence how the limbs are moving in that water necessarily. So it just gives you an idea of one against the other. So what's happening with the spinal movement in water? Now, there's only papers that have been published that have looked at the effect of water depth in horses. And so what they found, and I think it's perfectly reasonable to extrapolate some of this information for our small animal pets. And what they found is that as the water depth rises in the underwater treadmill, bear with me because I'm going to explain what each of these mean. We see an increased cranial thoracic extension. So what that is it's the higher thoracic vertebra, so up towards the base of the neck. They see more extension, so elevation of the head out the water. And what they put that down to was that they thought that as the water level was rising, they wanted to get their head away from the water. So possibly is why they're seeing that and why that was identified. They also saw increased caudal thoracolumbar flexion. So what we're starting to see now is the opposite. So we're getting flexion and lifting through the back. And that's most likely through the increase in water coming up under the belly and starting to have that buoyant effect. So bringing the thoracolumbar and the lumbar spine, as you can see, into flexion now. So putting it into a little bit more flexion. So if we've got a patient that's a bit sore into extension through its lower lumbar spine, we're actually helping make sure that we keep it into a nice comfortable position whilst we're exercising. And what we can do as the patient progresses and as we're happy with their progress, we can perhaps lower that water level to bring it back down into more of a neutral and normal position, which has got to do on land. But it's a way that we can influence what our patients are doing in the water. And that increases pelvic flexion as well. So you see that pelvis rock back, as I was describing, to try and see if we can optimize the space that those nerves are exiting their intervertebral foramen from. There's also stride length improvement as the water depth increases, reduced axial rotation, that means rotation left or right, so through the spine. I'm trying to explain it, this is not so easy, but essentially it's rotation through the spine. If you imagine you're sitting in a chair and you turn to the right or the left, the movement at which your body moves, the sort of the axes at which your body moves around is the vertical axes, and so it's that sort of movement in the dog. If you imagine you place that onto the horizontal plane, and then reduced lateral flexion as well. So there's less unwanted movement through side flexion of the lumbar thoracolumbar spine. Okay. Ooh. So there's another study as well that's looked at postural stability, and again this was only done in horses, and they looked at the land treadmill versus the water treadmill on postural sway in horses that had surgically induced carpal osteoarthritis, which is a bit extreme, I'm sure you'll all agree. They placed the horses into water at shoulder depth, and they found that the water treadmill therapy reduced postural sway out of the water compared to the land treadmill. So having treatment in the water treadmill improved the stability that horse had on land through different activities. And from memory, I think they blindfolded the horse as well to test how much sway there was. They had eyes open, and then they gosh, I can't remember. There was one other test that they did. I just can't remember off the top of my head, unfortunately. But basically, what they deduced was the water treadmill therapy activated the muscles that stabilized the limbs, and that improved balance and postural stability. So then we can look at the manual therapy, and there's lots of different manual techniques that we might use. This is a definition what manual therapy might include, and essentially it's skilled hand movements intended to produce any or all of the following effects, and that can improve tissue extensibility, so length, range of motion of the joint complex, might be used to mobilize or manipulate soft tissues and joints, can induce relaxation, change muscle function, modulate pain, and reduce soft tissue swelling, inflammation, or movement restriction. And that's a statement put forward by the International Federation of Orthopaedic Manual Physical Therapy. If I'm correct, I've probably got that completely wrong, but I must be close. So yeah, so there's different examples. So on the left-hand side, we've got a picture here of a dog having some soft tissue massage, and that can have a nice effect in that it will reduce anxiety, can reduce stress, and improve mood. Sleep and depression is just some of the nice things about it, but also from a physical point of view, you get that endorphin release. You can get pain reduction as a result of that. It can be used to reduce swelling and muscle spasm, can reduce nausea, enhances pain tolerance as well, and relaxation as well away from that muscle site as well. So we all love a massage, for those of you that have enjoyed it in the past as well.
Can't wait till we're allowed to go back for massages.
Absolutely, there's the small pleasures, isn't it, that we've all been missing. Then in the centre there's stretching as well. Obviously this is mainly for the distal limb, and then also we've got joint mobilisations as well, and a lot of physical therapists that have a human background will also utilise these techniques to improve. Well, we like to think we have a biomechanical effect on movement within the joints. However, we know it's short term but not long term. I think realistically what effect we are having is more on the neurophysiological parts of the body. So we're essentially overriding the pain messages to the brain, and dampening down the painful response, essentially the pain feeling. So we do joint mobilizations in different ways. We can do them passively, so we can essentially move the joint through their full range of motion. You can do that in the lumbar spine as well. So if the dog's inside lying and relaxed enough, you can do a passive physiological range of motion. But a lot of practitioners who use these techniques might do the accessory mobilization techniques, and these are unobservable roll, glide and spin techniques. And you need to basically, if you imagine your what's an easy joint to use? I guess the knee joint. So if you're flexing your knee is bending essentially, but what's happening within that joint? You've got a concave surface on a convex surface, and as you flex the joint, it's not just bending. Essentially, what's also happening within the joint is that it's gliding in one direction. And so if we wanted to improve flexion because it was stiff, we might be utilizing a force in the direction that might promote that glide as well within the joint. I don't know whether I used the best example there, but hopefully it makes part sense. So the evidence to support that they improve pain, we'll talk about the pain gate theory on the next slide. And also we talked about the biomechanical effects that we're hoping to achieve, so hoping to improve movement. And I know that some physiotherapists will feel that because there's so much high motion going through the lumbosacral junction, if they can improve a little bit of the movement above that, it might take the forces off the lumbosacral junction. So you might find that some patients respond well to mobilizations of the vertebra just before the lumbosacral region, because if you can promote a little bit more movement through those vertebra, are we taking the forces off the problematic area essentially and making them more comfortable? So the gate theory of pain, as I mentioned, we're using essentially, well, you can use massaging or application of heat, but also joint mobilizations to target the large peripheral nerve fibers. So they've got large diameter nerve fibers, and because they are of that size compared to the smaller painful nerve fibers that we know the pain stimulus to come from, then we can send messages to the brain much quicker. So we override the painful messages to the brain through this inhibitory neuron to the transmission cell that then travels up to the brain. So that's why we know that this works, and there is lots of studies that have looked at that as well. Now, I I just wanted to touch upon fascia. I'm not an expert. I know there's been lots of people that have spoken on this before for CAM, and hope they don't say anything incorrect. But I just wanted to touch upon fascia because we mentioned myofascial release and why it was important. And I've got a lovely video, which I know that Hannah's referred to previously in her live, which I wanted to show on here because I thought having her touched upon that, I thought it'd be lovely to show you what she was talking about. But basically, fascia is a densely woven, continuous connective tissue, and that attaches, stabilizes, encloses and separates muscles and other internal organs. And it's made up of collagen and elastin as a ground substance, and has these reticular fibers as well, which will create this binding, essentially. It's in a 3D plane, which allows it elasticity, and it sort of shears and has good strength. And it's really richly innervated by mechanoreceptors and nociceptors, which are your pain nerves, essentially. There's lots of interstitial body fluid that surrounds it as well, and this is why it can become dehydrated when there's problem areas. And it does have a passive and dynamic function, so it works in a static position, and it is important when you're moving and doing dynamic activities. And it does have a role in postural loading, which is essential for the dynamic stability, so that stabilization you need before executing movements and moving your extremities. And for the thoracolumbar area, we do have the thoracolumbar fascia, which also contributes to extension, lateral flexion and rotation. But what I love about this video, which hopefully I'm just going to have to flip out again, so bear with me. This is for a minute and a half, and I think it's worth watching all the way through. So bear with me. Hopefully the volume's up.
Cody a pretty severe myofascial restriction at his right hip. Good. Now, first of all, can you see how Cody has started to kind of develop some interesting posture? Good. Cody, try to lift your arms for me, please. See where the restriction is? It's even worse than before, by the way. Did you notice that? And then drop the arms back down. Now, Cody's going to attempt to walk with this myofascial restriction. So we're going to go for a little walk. And he's going to walk a little bit interestingly, right? Okay. And we're going to back it up so we don't fall in Dr. Rob. Good. Okay. So what I want you to see is that, first of all, you already saw how this affects his shoulders. Think about his neck. Can you imagine what might be happening at this hip over here? How that might be compensating and actually wearing on things, maybe even wearing cartilage from the position. Of course, this hip is probably not very happy, and this knee could have serious problems. With this pattern, Cody can have plantar fasciitis on his left foot because it has to deal with severe loads and modified impact with every step to try to stabilize him. This is the interesting with fascia, where you think it is, it ain't, okay? And the other point is, can you imagine his lumbar spine? I dare anyone to go for a walk with this. Half an hour. Tell me how your back feels. Okay, so I'll set Cody free, proverbially and literally. Thank you, Cody. Everybody please give him a hand for being important.
So hopefully that's a really lovely illustration, I find anyway, of what fascial restrictions can do to the body. And essentially you can get this fascial tightness in an area of the body that isn't moving. So if you've got the lumbosacral disease and a dog that's not wanting to move, then you're going to get these myofascial restrictions. You're going to get essentially a sort of thickening of the fascia because it's not moving and gliding in the way it should. It can become inelastic and you can get adhesions forming. And they can become very dehydrated as well. And that can result in some cases, myofascial pain syndrome, which are caused by these trigger points within the soft tissue, or within the fascia, sorry. So, and those can be characterized by a taut band of muscle. You can get referred pain, which is the sensory component, and that can refer to anywhere in the body. And then you can also get the local fasciculation, and for many of our rehabilitation therapists, they'll be identifying or assessing for that during their assessment, and you'll see twitching of the muscle and you'll think, oh gosh, what have they found there? And most likely it's related to these myofascial trigger points as well. So you can get active ones that refer on the nerve pathway, you can get latent ones which don't refer anywhere. And then you can get the silent ones, which are painful on palpation as well. So this is why we're really quite interested in these myofascial trigger points. And then we use myofascial release as a technique to treat these areas. So sustained pressure can help reorganize the collagen fibers, essentially, because they start to become a little bit disorganized. They can be hydrated, so you can see on the middle image there, you've got the dehydrated fascia on the left-hand side and the hydrated fascia on the right-hand side. So it looks much more happier. And then it's used to aid a release of adhesions. And it's a safe and effective hands-on technique that involves applying gentle, sustained pressure in those myofascial connective tissue restrictions to eliminate pain and restore motion. And if you imagine you've got a grapefruit in your hand, what you might want to do is, before you juice it, is you might roll it around your hands and squeeze it a little bit to try and break up the fascial walls, which will make it easier to juice. And that's what we're essentially might be doing, or are doing, when we're doing this myofascial release technique. And so it allows the juices to flow freely to those dehydrated areas of our body. And then I'm just going to touch briefly on laser therapy, as I know many of you probably have a good awareness of this. And this is the application of specific wavelengths of light for a therapeutic effect. It interacts with the tissues at a cellular level and increases the cell metabolic activity, which will help improve transport of nutrients across those cell membranes. So optimizing the cell function, essentially. And that can help enhance tissue healing, pain relief, and boosting the immune system. And it has that anti-inflammatory effect or mechanism by inhibiting the release of pro-inflammatory substances. And I was talking to Amy just before we went live this evening, so I was doing some reading around this subject. And then, unfortunately, there's been a couple of papers that are published in the last 12 months that haven't really shown this in good light for lower back pain, for chronic lower back pain. But it was used as a standalone treatment. And although I do use this for my lumbosacral disease patients, I use it as an adjunct. I use it with other treatment approaches as well, or treatments. So I think it really needs to be considered in that light as well. And I didn't have time to look more deeply. I know that one was a systematic review, which means that they've looked at lots of papers and lots of research that has focused on the use of photobiomodulation therapy, as it's otherwise known as, or laser therapy, to look at its effect on chronic lower back pain. So, but yeah, there's new information coming out all the time, and I think we sort of need to look at our patients. Anecdotally, I find it helps my patients, and I use it prior to exercise therapies to basically optimize their pain relief, make sure that they can engage in the treatment sessions as well as they can do to optimize the return on your rehab, essentially. So, and that also applies to the pain relief as well, the anti-inflammatories and pain relief, because I have a lot of owners that will come to me and they'll say, well, I feel that the pain relief, I think the medication's masking symptoms, or I don't want my pet on pain relief for very long. And the way I say to them is that I think it's really important that their pain is well managed, because if it isn't, you're not going to get correct engagement of soft tissues. You're not going to get the return on your investment in rehab, your pet's investment in their rehab. Is going to be a much longer road to recovery if they're not on appropriate pain relief. So it's really important. And I guess just to finish off as well, that also applies to the epidural steroid injections that we work with patients that undergo a course of treatment via that route. Is optimizing pain relief, making sure they're as comfortable as possible, and then continuing the targeted therapeutic exercise that we then do in-house, and that might include underwater treadmill therapy too. So that's all, folks. I'm sorry, that's probably dead on an hour, so I'm really sorry, but I'm happy to stay all evening and answer questions, Amy. So
bless you. That was amazing. Thank you. It was so good to see all those videos and sort of get a real picture of sort of the maladaptive changes that we might see, and then go from there. There are quite a few questions that have popped up. Are you sure that you're all right to stay, and we'll just go through a few of them?
Of course, yeah.
I'll just scroll up to the beginning just to make sure I don't miss anybody out, because there was a few. Let me just see. Oh, Lindsay's written that one of our Whippet girls has had an MRI in September, and it turned out that she had disc compression at the Lumbosacral Junction. She has had an op to remove it, and then 4 months later she had a slip disc in her neck and 2 dehydrated discs. She was 8.5 then when she had her first op, and she's now 10. But otherwise she's doing well, so that's nice. Let's see if there's that was the question. Let me just have a look. Oh, here, this is a good one. I'll bring this one up so we can all see it. My German Shepherd dog was diagnosed with lumbosacral transitional vertebrae and has significant weakness and uncoordination in his rear legs. His vet says it's because of this diagnosis, but the neurologist says it's not. He's had an MRI which showed a protruding disc. He jumps, climbs stairs with no issue and shows no sign of pain, so we're stumped. Have you got any sort of words of wisdom
the only
from
thing
a physio perspective?
I think I did read,
isn't it?
when I was preparing for this. Yeah, I think sometimes the MRI scan doesn't always correlate with the clinical signs. So I think
Tom was saying that, wasn't he?
Yeah. So
yeah.
I don't think I have anything more to add than that, really. I think if he's got uncoordination and weakness still, and the neurologist doesn't feel it's, did I read it right? It didn't feel it was related to the disc, or
he didn't feel it was related to the previous diagnosis of lumbosacral transitional vertebrae.
Okay.
But then he's since had an MRI which showed a protruding disc, so it may be that the protruding disc is potentially having some impact there on the mobility issues that we're seeing.
Yeah, and obviously I don't know what the management is for that patient as well, but I think it's really being cautious over continuation of those activities. I think even though he appears comfortable, it's what the long-term impact might be on continuing that as well. So.
Yeah, absolutely. Yeah. There's one about laser therapy here. What are your thoughts on cold laser therapy? So, because you brought up that paper, it was looking about laser and heat being actually really beneficial. But that's cold laser therapy.
Yeah. So I think it depends on the type of laser that you use, because I use a class 3B laser rather than a class 4 myself, for the therapeutic effects that I'm aiming to achieve. I guess the term between cold laser, I don't really use that terminology. So we referring to class 3B versus class 4, where you can get more heating effect. So if that is the case, then I use it in that sense. I'm afraid I don't use that cold laser so much.
Yeah, no, that's fine. That's great. And then Penny Barnes has just written, how do you define modified exercise? I think it's right at the start of the presentation when we were talking about how, to begin with, it would be sort of non-steroidal anti-inflammatories and rest, and then sort of looking at modified exercise going forward. So if you're happy to sort of...
So I think certainly it depends on the neurologists and what their recommendations are. As you know, in the human medicine, they don't support strict rest. It doesn't show improvement in pain or function in any way at all. So it's to be dismissed essentially. So I would be inclined to say strict rest shouldn't really be on the cards for our small animal patients. I think controlled lead walking is quite important, little and often, in the first instance, and that can be just starting off with 5 minutes essentially. But it's also really important to maintain muscle mass as well, certainly in the hind limbs. And then it was a term moderated, wasn't it? I used, was it?
Yeah, modified. Yeah.
So it really is just, I normally recommend, it depends on the patient's previous level of activity, but my normal recommendations is add 5 minutes to each walk per week, and that can be done in a fairly controlled way, and the owner can monitor for when it's too much to really strip it back down. And things that you might see in this particular case might be increased scuffing of the hind limbs, which might be showing signs of fatigue or discomfort or irritation. So you're really monitoring for the clinical signs that you know your pet has suffered from previously, and trying to stop from getting up to that point. So I think modified exercise in that sense, so you're in complete control of what you're doing and increasing it gradually. Sometimes if there's patients I feel I can do, I might add more time onto that, so adding 10 minutes on to each walk per week, but it's very rare that happens.
That's really helpful, thank you. And then Mikhail has just asked this question, I'll bring this one up. I think that was when we were talking about what is the relation between LTV of L7 to S1 to lumbosacral disease? What do you mean by LTV? Do you mean lumbar thoracic vertebrae?
That's what I was guessing.
That's what I'm thinking. Let me see. No, they're not. Okay, well, we'll leave that one. If Mikhail, if you're still there, can you just let us know what you mean if our interpretation of that is correct, and then we might come back to you. There was just one more. This lady, Becky, for how long should a dog do treadmill exercise? My girl has been doing it for a year, plus drugs and steroid injections as conservative management, and now they're talking about surgery. Should I keep her doing the treadmill? My insurance won't pay out anymore, so I stopped this in the last 6 weeks. But if it is really important for her, I'll find a way to pay for it. She was due an MRI today, but the machine was broken.
I think it would be helpful in the post-op period if she is going for surgery, certainly. I think hopefully you've achieved is some pre-surgical conditioning. So, we sometimes talk about, what's the term we use? Can't remember, it's gone. But essentially conditioning the patient prior to surgery, so making sure that you're optimising the conditions of the soft tissues, and so hopefully speeding up the recovery. But I think certainly in the post-op period, it might be beneficial at the right stage of her recovery, and you'll need to be guided by the neurologist on when they're happy for her to have that. In our practice, we would normally be happy from approximately 2 weeks post-surgery, so we tend to get them in, and as I mentioned, you can be in complete control of the parameters, so you take it very slowly in the first instance, and from what your dog has previously done in the past, I'm sorry I've forgotten the name, but if they were doing quite a lot in the past, then don't be surprised if they have to strip that right back down in the first instance to make sure that we don't aggravate any structures in the immediate post-op period. So I would say, depending on how soon surgery is, then you may be able to hold off until that. But if you, I guess there's also the possibility if you are able to practically is continue to condition your pet before surgery too.
Yeah, just to stop that muscle atrophy and that weakness.
Yeah.
So hopefully. And there was just Nicola has written. She's also used. I'm sure it is lumbar thoracic vertebrae, but I'm not sure. What physio exercise or electrotherapies would you perform given that it's a mechanical issue and not going to improve? So L7 with respect to the sacrum. So I think that's what she means. Does that make sense?
Sacral joint. LTV. I'm trying to think. It's
lumbosacral transitional vertebrae. They've just. Thank you, Mikhail.
That's not going to improve. I would say, electrotherapies we talked about. I primarily use laser. However, as I alluded to, we were talking about what the recent papers have shown for chronic lower back pain in human medicine has shown us that it's not effective for pain and improvements in function. I think it's really important to maintain the core stabilizers and dynamic stabilizers of the spine. And as she said, if it's a mechanical issue that's not going to change, I think it's really working to ensure there's no excess compensatory patterns happening elsewhere in the body as well, and monitoring the effect of that on the rest of the body to minimise the onset of further problems down the line.
That's great. And then Liz has just brought up this one. Following L7 decompression and further diagnosis of L7 bilateral foraminal stenosis, my dog continues to offload his right leg. What exercises would you suggest to try and get him to utilise this and his hindquarters better, please? I think that's really difficult with that hands-on assessment, really, isn't it? So I don't know how you feel, but it would probably be better to go and see your vet and have a referral to a physio, and they'll be able to sort of properly assess in person and give you a sort of a really tailored, specific plan going forward that is specifically for your dog. They can assess sort of like where the muscle weaknesses, or where sort of the imbalances are, or the atrophied muscles are. Do you have anything to add, Diane?
I agree. I think you need to make sure there's not pain elements still present as well, so before you can deliver any specific exercises.
That's great. I think I'm sorry if I've missed a question, but I can't see any more when I've been scrolling up and down. I just want to say thank you so much, Diane. It's been such a lovely evening and a brilliant presentation. And there's some lovely comments saying thank you. It was a great presentation, very informative. Thank you so much. So from all the CAM followers, thank you for giving your time to teach us more about this complicated disease process, and sort of the more physiotherapy and rehabilitative side, and how we can help our dogs. So thank you.
No, thank you, Amy. It was a tough follow-up to Tom's amazing presentation last night, or talk last night. So hopefully it'll help.
No, it's been great, and it's been lovely to have the two perspectives, actually, one from sort of a neurosurgeon, neurology perspective, and then your approach as a physiotherapist, and then sort of putting them both together. So it's been really great to sort of finish off that picture. So so just before we leave, I do want to just make CAM followers aware that there is a fantastic course. So Hannah has put her heart and soul into the Cambassadors course, but she's also got an owner's course coming out. So keep your eyes peeled for that, because that's coming out in the next sort of couple of days time, or couple of weeks. And she's also got a children's book out where her dog Holly is sort of the star of the show, and it goes through all the signs that your dog might exhibit, and how to understand that as a family, that it actually might be pain, or there might be something going on there. And I think it's called Why Aren't You Listening? So if you want to check that out, that's on the CAM site too. So we're going to end tonight. Thank you so much for joining us, and I'm sure we'll get Diane back soon because she's so great. And I'll see you next time. Bye.
Bye.